Welcome to Healthcare 101, where we're going to look at the basics of the U.S. healthcare system. So what we are going to do today is I'm going to briefly talk about who I am and then go into details of what economics is and how we can use it to examine the basic healthcare system in the United States. And then we're going to roll up our sleeves and go into a little bit more detail on our health insurance approach in the United States and how it compares to other countries and some of the proposals to make change in that area. And then we'll obviously summarize. My objective in this talk is this is one of the more divisive topics in all of healthcare, how we approach our health insurance. And so my goal is to give you a non-politically motivated, objective overview of the different approaches and highlight the positives and negatives of those different approaches. I think we all can agree there's enough opinions out there on this topic, so I just wanted to give you just the facts on both sides of this situation. A little bit about myself before we get going. My name's Erin. I have a PhD in economics. My area of specialty and research is healthcare economics. I am on the economics department faculty at Seattle University. Prior to becoming a full-time academic, I worked at the Federal Reserve Board in Washington, D.C., and also did some consulting. We are going to start by talking about what economics is and then go into how we can use it in this specific context. Economics is a social science. So let's start with the word science. What this means is in economics, very similar to the physical sciences, we have a hypothesis, which we then, through statistics, empirically examine whether or not we support that hypothesis after we look at the data. So it is an objective methodology of examining situations. Where it is different than, say, the physical sciences is that it's a social science, meaning we study human behavior. And so it gets a little messier because unlike a lab where we can hold everything else constant and, say, change the amount of liquid going into a solution, we can't tell humans, don't change anything else going on in your life because we want to examine how this policy changes your behavior. It gets messier, but at its heart is this objective science. And why it is required not only in business majors, but across multiple majors in a university is because of this concept of scarcity. So an item is scarce when there's not enough of it to meet everyone's wants. And most items, most resources in our world are indeed scarce, and economics is the social science that studies how we make decisions in light of this scarcity. So we examine individuals with this concept that we know they cannot do it all. We're almost all limited by income, and those of us who are fortunate not to be limited by income are limited by time. So no one can do it all. So how do we make the decisions we do? It studies firms in light of scarcity, companies. So how do companies decide what to produce given they can't produce an unlimited amount of goods and services, and they cannot hire an unlimited amount of people? So where do they make those hiring and production decisions is something economics looks at. And from a big picture level, in terms of policy, we start with the scarcity concept, knowing that no government policy is going to meet the wants of every individual. So starting with that, how can we do our best in terms of the way we set up our society? So healthcare economics is tied to scarcity as well. It acknowledges that scarcity exists even in healthcare. Meaning, for example, not every single person who walks into a hospital is going to get everything they want, just because we can't do it all. So we look at why hospitals choose to have the resources they do on hand, both in terms of equipment and the types of doctors and nurses. We look at how insurance decides what to cover and what not to cover, because you cannot cover every procedure for every single ailment for every person. It's just not realistic given we have scarce resources. So how is the U.S. healthcare system doing? It is too complicated to have one single number and say, we're doing this well compared to other countries. So what we do as health economists and policymakers in this area is we look at three different aims and see how we're doing within those three areas. And then we take a step back and say, is there a way we can help in one area without hurting the other two? And what are those areas? So the first is cost. How expensive is our system? The second is, of course, is how are we doing? Some measure of quality, of success of the way the healthcare system is set up. And then the third big bucket area is access. How accessible is our country's overall healthcare system? So we are going to spend one slide on the first two, but the focus of today is going to be this access issue, as we talked about before. So let's look at cost first. We're winners here, but not in the direction you'd want to be. We have the most expensive healthcare system in the world. Per person, we spend over $10,000 per year. So one argument to this is healthcare is important. Our health is important. So maybe we spend more because we're a wealthier nation and this is an important expenditure. But even if we look at by percentage of income, either individual or national income, GDP, we spend a higher percentage on our healthcare compared to any other country. So a second argument would be, well, maybe we're spending more because we have better quality, we have better health outcomes. So let's look at that in the next slide. So very few would argue that overall that our quality is bad. We have good quality. We do pretty well in this area. But knowing we spend significantly more, there are other countries that are doing just as well, if not better. So here are some quality metrics within the healthcare system. These are mortality rates normalized for population. And so you want these lower, all else equal. And the blue is the United States. So if we look at diseases of the circulatory system, that is heart attack and stroke, mortality rates, you can see we're not doing as well as other countries that we like to compare ourselves to. The second one, neoplasms, that's cancer. If you have cancer, you want to be in the United States. Our mortality rates are lower, very successful survival ratios in terms of cancer. So we have a good system, and you can see other major causes of death. We're doing okay, but knowing we're spending so much more and doing well, but similar to other countries, is a concern. What is going on? On top of that, behind these averages, the U.S. has more on average disparities across demographics. So if you break down heart disease by ethnicity and race or income level, what we see is a large disparity in terms of these health outcomes. And that is partially tied to this third bucket of measuring how well a healthcare system's doing, and that's how accessible it is. Our final measure of overall success of a healthcare system is access. And the go-to basic measure of how you're doing in terms of access is the percentage of the population that has quality health insurance. And we have about 10% of our population without health insurance. And this is a public health problem. People are not seeking out needed medical care because of costs. So our health statistics are lower. And it's an equity issue too. Is it fair to block a percentage of your population from the healthcare system, with the exception of the ER, when a lot of times treatment is too late? So let's think about how we're doing. This is obviously problematic. It's contributing to health disparities across demographics. How does this compare to other countries and how they're doing in terms of access? So in terms of percentage of the population that has insurance, our 10% that doesn't have it is very unique compared to the other countries that we compare ourselves to, generally speaking. And so what we're going to do in the next few slides is, first we're going to talk about insurance in its most general definition. And then we are going to go through some of the different approaches these countries take. There's multiple different ways to achieve 100% of your population having insurance. So look at what they're doing and how it's different in the United States. First, we're going to talk about what insurance is. So insurance has been around since literally ancient times, and the first known type of insurance was actually farmers taking their crops downriver, and inevitably someone's boat would crash and they would lose their livelihood for that season. And so over time, what happened is the farmers would spread out their crops across multiple boats. And so when the boat would crash, everybody would lose a little bit, but no one would have a catastrophic event happen. And insurance really hasn't changed from that ancient time period, where it's protection from low probability. It's probably not going to happen to you, but if it does, it's a high cost event. Across time, you can see how some entrepreneurial spirit said, you know what, it's kind of a pain for us to split up our crops across boats. Let's all use our own boats, but set aside a little money. And for the unfortunate one whose boat crashes, we give them that money. And so insurance really hasn't changed. Individuals pool together. When you get a decent amount of individuals together, 100 or so more, statisticians can predict with incredible accuracy the expected total, in this case, healthcare costs of that group. So obviously they can't say if it's going to be me that's having a heart attack or you, but they can give us very accurate statistics of what percentage of us will. And they calculate the total payouts of our group. And then insurance essentially is all of us pay a portion of the payouts. And that's known as an insurance premium. It's what we pay for insurance. And it's that little bit of money set aside that then goes to pay for these high cost events that the unlucky individuals get. So insurance like this, health insurance, fire insurance, has worked successfully for generations. I am going to, in the next few slides, go over how other countries have attained 100% of their population having insurance. And I wanted to, obviously I'm simplifying this, but I wanted to highlight a couple things. That blue means there's heavy government involvement within the insurance, and red is more the government leaves it up to private institutions and markets to work out the details. We're going to start with countries that have single-payer systems. And here's an example of 4 countries. There are more, but they're essentially very similar to these. And these are countries that, via taxes, pay for the baseline health insurance of every single citizen. And that health insurance has the essentials covered. But in every single instance, notice the red font, is individuals can pay for more insurance. In Sweden and the UK, about 10% of the population, so essentially those who can afford it, pay for supplemental insurance that allows them to avoid the lines that are often existing with single-payer systems. So if the wait time is 50 days to get some MRI, if you have the supplemental insurance, you could go somewhere else and get in maybe within the week. So it's a way to avoid the wait times and have more choice. Australia has Medicare, actually it's called Medicare, for its entire population, and essentially that gives everyone access to public hospitals and doctors. Over half of their population pays for additional insurance that gives them access to private hospitals and doctors as well. So it gives them more options, and they are welcome to use the public hospitals, and some do even if they have private insurance, just because they're closer, but that gives them the option of more doctors. France has a baseline system for everyone, health insurance, but it is very baseline. And in all of these countries, not all of your health care is paid for. You have to pay a portion of it. So you have insurance protection from low probability, high cost events, but you have to pay some along the way. And in France, what you have to pay is actually pretty high for a lot of procedures. So you can see 92% of the population buys supplemental insurance that sometimes protects them from these high shared payments of procedures. So a lot of single payer systems exist out there, and what we see is on top of that, there's a private insurance market in all of these countries. Canada gets its own slide. It's a single payer system, but it's not at the federal level. Each province runs its own single payer system. And there's obviously federal guidelines in terms of what they can and cannot do. But the bottom line is the essentials are covered. But because of scarcity, not everything is covered. So there is a private insurance market in Canada as well to cover medical procedures that are not in the province's plan. And as you can see, about 2/3 of the population in Canada buys insurance on the private market to help them pay for things that the province single payer system plan does not have. There are some countries that have 100% of their population insured, but it's not a single payer system, meaning the government does not provide the health insurance. So we're going to go through these individually, 3 countries, because this is closer to what the US at least currently has, and see how they are different in terms of not having 10% of the population not having insurance. So we'll start with Japan. Japan has multiple, over 1,000 insurance options that companies can choose between. So in the United States, a lot of us have insurance through our companies. In Japan, it's mandated that companies provide insurance to all their employees. So it's a little bit of a stronger mandate on the company side. And in addition, if you do not get insurance through your company, you are automatically assigned and have to pay for the insurance of your local city workers. So whatever insurance the police force and firemen in that area get is what you are given. So there's no option to buy insurance. The employers get to choose a lot of different options, and those options are very similar to what we see in the private market in the United States in terms of Aetna, Blue Cross, kind of examples like that. But as an individual, you either have whatever your employer has chosen, or you get auto-assigned your local municipality's insurance. For all of these examples that we're going to go through, for the low-income individuals who cannot pay for insurance, it's provided for them. But if you can pay for it, you are just assigned it and charged it. And in all of these multi-payer systems, there is some government regulation in terms of what must be covered and how it's covered. So it's all decent, high-quality insurance. There's no major holes or exceptions to the rule, meaning like if you get really sick, you lose your insurance or not. It's all deemed as high-quality insurance. Germany doesn't have the employer mandate that Japan has, but it has an individual mandate. So you have to buy insurance, and you can choose from over 100 different, they call them sickness funds, but they're insurance plans. Again, very similar to what we have in the United States if we're covered by a company's insurance options. A little bit different in Germany compared to the other options is premiums are not based on expected payouts, and they're not the same for everyone. They're based on your income level. So for example, if you and I both choose the same insurance option, but you make twice as much as me, you're going to pay twice as much for that same insurance option. Similarly, the penalty to not buy insurance will be different, but for both of us, it will be more expensive for us than buying insurance is. And that's how they achieve 100% coverage, is the penalty to not buy it is more expensive than the actual insurance that we would buy. And again, that cost is income based. And similarly, those that don't buy insurance at all, those that cannot buy insurance at all, get it provided for them. Similarly, the insurance market, although they're private companies offering these insurance plans, the government gets involved in terms of regulating what a quality plan must have in it to be offered in Germany. Switzerland, you always hear Switzerland when you have these sessions on comparing the US healthcare system. Why that is in the 1990s, they had an uninsured population very similar to the US, and then they made strides to eliminate that and move to 100% of their population insured. And they're very similar to Germany. They have a mandate to not buy insurance. They left it up to the cantons, so the equivalent of a state, to determine what the penalty is. But essentially, in all cantons, the penalty is more expensive than actually buying insurance. And again, the government helps out those who don't have the income to buy insurance, and insurance is regulated in terms of what can be in these options that the individuals purchase. I just want to summarize something. If you go back a few slides, insurance is protection against low probability, high cost events. So for insurance to work like it has worked since ancient times, you need everybody buying into the system, or specifically, you need healthy people buying insurance. If you just have sick people buying insurance, health insurance, that's not health insurance. That's someone wanting to cover guaranteed bills. So how do you get healthy people to buy insurance? The single payer system is pretty easy. They're paying for their insurance essentially via taxes, and so everyone's automatically paying for their insurance. In the multi-payer systems, how we get the healthy people there is what we've seen examples of are the first two. Japan just auto-assigns. It's not a choice. You either have your employer insurance or your local municipality insurance. Switzerland and Germany, they get the healthy people there by saying, hey, if you don't buy insurance, it's actually going to cost you more. Your penalty that you have to pay the government is more expensive than the insurance that you're foregoing. If you leave it up to the private markets, saying the government doesn't have a rule or a mandate, how does the private health insurance markets, without help from the government, protect themselves from people waiting until they're sick to buy insurance? And what we've seen is the insurance companies essentially will exclude people who are sick from buying insurance. And this is what we saw prior to the ACA. So prior to 2010, in the U.S. health insurance market, where we didn't have a mandate and we didn't auto-assign people to a certain plan, we had what was known as a pre-existing conditions exclusion. And essentially, if you don't have insurance and you get sick, you could not buy it. Now, the rationale from this, let's talk about fire insurance and then we'll come back to health insurance, is would you find it unethical for a fire insurance company to deny coverage to someone wanting fire insurance while their house is in the middle of burning down? And most people say, well, no, they shouldn't be able to get fire insurance because it's not protection from a low probability, high cost event. They just want fire insurance so they don't have to pay for their house being rebuilt. Health insurance could be argued that it's the same. Health insurance, by definition, is protection from low probability, high cost events. But most people find, including lawmakers in the United States, because we changed this rule, is there's something different with health insurance. And there seems something morally wrong with saying to someone, oh, you didn't have health insurance and now you found out you have cancer, well, you can't buy it now. There seems something not quite right with that. But just keep in mind that if you allow sick people to buy insurance, you have to have some way to incentivize the healthy people to buy it too. So just keep that in mind. But the free market's approach to incentivizing healthy people to buy insurance, the pre-existing conditions exclusion, was seen as not right. And that was at what the heart of the Affordable Care Act was to change that issue. And so let's talk about where we are. We looked at other systems. Let's talk about where we are. So the U.S. system can be summarized by just a single phrase. It's complicated. So let's talk about most of us who are working are covered by company options. And there are options for those of us who aren't working to choose insurance that's similar to those of us who are working and get it through our employers on individual markets. Now, we eliminated the pre-existing conditions exclusion. So health insurance companies in the United States, since the Affordable Care Act, have to offer insurance to everyone, even if they're sick. And the way we incentivize healthy people to buy insurance before they were sick was we copied Switzerland and Germany and we put in an individual mandate. Notice that the individual mandate has been eliminated In 2018, the Republican Senate passed a massive tax overhaul, and they, at the last minute, eliminated the mandate, that essentially a tax on people who didn't buy insurance. So we no longer have the mandate, but we did have it in the original Affordable Care Act. One other thing the Affordable Care Act did, which actually has support on both sides of the political aisle, is those under 26 can still be under their parents' plan. And this is a great way to get generally healthy people to stay on their plan at a time when they may not have the funds to choose it themselves if they're on their own. So that is something that the ACA added that has general support. We also emulated all the multi-payer systems, and we got more involved in what health insurance is. Prior to the ACA, some people were buying plans that in the small print disappeared if you got sick and spent more than a certain amount of money on health care. And that was deemed as not quality health insurance and made illegal during the ACA. Now, that is also, that regulation is being loosened. Trump has allowed plans that don't meet the ACA or Obamacare, it means the same thing, requirements to enter certain markets in the United States. So what is being offered as insurance in some states that don't have their own strong regulation is not meeting the basics that most policy experts across the world deem as sound insurance. So since 1965, the over 65 or the 65 plus crowd in the United States actually has a single payer system, and it's known as Medicare. But one thing I want to point out is it is decent insurance, but it has some holes to the effect that about 2/3 of the population buy additional insurance. So 2/3 of the elderly population have insurance that helps with the holes that Medicare doesn't cover. And it's scarcity. A single insurance program, whether it's government run or non-government run, cannot cover it all. And so there is a private market, very similar to the individual market for younger people, to buy additional insurance that sits on top of Medicare. The ACA also made changes to Medicaid. Medicaid was passed in 1965 along with Medicare. And this was to help with the low-income population. And at the time of its passage, it's a state-run program that gets help, federal funding help. But essentially, the states chose who qualified for Medicaid. And in the vast majority of states, to qualify for Medicaid, you either had to be disabled or a single parent. And this caused problems, and what we saw empirically is in low-income areas where that was the qualification, it should come as no surprise that the divorce rates increased, the marriage rates decreased, because people didn't want to lose their Medicaid health insurance. So what the Affordable Care Act did to eliminate those social issues tied to people really wanting to keep their health insurance is they said, okay, anyone making below 138% of the federal poverty level, that's what FPL is, and that is about $16,000 as an individual person. So anyone making below that in any state will receive Medicaid. And that eliminates the social issues of not wanting to get married or getting a divorce just to cover your health expenditures. On top of that, the ACA, in a goal to increase the amount of people insured, said, we don't want people to experience what is sometimes termed as welfare lock. And that example would be, let's say I have a $15,000 a year job. Because it's below the federal poverty level, 138%, I have Medicaid. I'm offered a better job that makes $20,000. I don't take it because I would lose my health insurance. To eliminate that barrier of me accepting a better job, if anyone makes between about $16,000 and about slightly over $40,000, you get help from the federal government. And if you're making, near 138 federal poverty level, you're getting the significant portion of your health insurance paid for by the federal government in the form of a subsidy at the end of the year. And that's a sliding scale, where as you make more, you get a little less of it paid for, but it eliminates this concern that people aren't taking better jobs because they'll lose their health insurance. So a couple things, the black on these notes is the original ACA attempted to have this be all states expand their Medicaid coverage. The federal government would fund, at the end of the day, 90% of this expansion. The Supreme Court ruled that you can't make states change their state-run programs, so this is optional. So only in participating states do we have that top bullet of everyone making below $16,000, regardless of who you are, qualifying for Medicaid. And then the subsidies to get rid of the welfare lock concern is Trump hasn't talked about the details, but in 2019 he had mentioned a couple times that he will eliminate the subsidies due to a deficit. So that's just something he said offhand to be on the lookout for. He hasn't, to my knowledge, taken steps to that other than acknowledge that he wants it to be gone. And what we have is 10% of the population, even with these ACA changes, still does not have a health insurance, but the ACA did take a bite out of our uninsured population. Before the passage, we were up to 18% of the population not having health insurance. Let's go back to the Medicaid expansion. So these are the states as of right now that have expanded Medicaid. So there are 14 states, the dark blue, that have not. And this is becoming more of an issue with COVID-19 causing unprecedented, prior to the Great Depression, unemployment rates. Is a lot of individuals are losing not only their job, but their health care coverage. In the light blue states, they will most likely qualify for Medicaid because they'll be making under $16,000. So by definition, they'll qualify for Medicaid. In the dark blue states, the percentage of uninsured is anticipated to increase substantially because in most of these states, you need to, again, be a single parent and or have a disability to qualify for Medicaid. So we anticipate the uninsured population in these 14 non-participating states is going to go up. And that's not to say that the participating Medicaid expansion states is all great during the COVID-19 crisis. They're going to experience budget issues because they're going to have significantly more individuals under Medicaid, and they fund some of the program. Some of it is federal funding, but they fund 10% of it. And so they might be experiencing significant budget issues tied to having people come under their Medicaid umbrella. But at least they will have access to the healthcare system at a time when they most likely will need it. So these are things to keep in mind. For the adopted states, their budget shortfall, which is something there is a hope that the federal government will fund Medicaid a little more than they normally do in non-pandemic times. And then also the concern about the uninsured populations that are already higher in the non-participating states becoming even higher. Okay, so we have an uninsured population. It is getting higher now that the mandate is gone. So some of the healthy people are leaving the plans because they don't have to pay a penalty. This is causing health insurance premiums for all of us to go up, which is then causing other people to choose to forego insurance because the premiums are going up. So we have this issue, and there are some proposals in terms of how to address the healthcare situation to change. So my goal in these next few slides is to talk about this is where there's a lot of divisiveness on the political spectrum. So my goal is to just objectively tell you what it is and talk about the arguments for and against. We're going to start with Medicare for All. Obviously, these two candidates, Warren and Sanders, are no longer running, but their healthcare plan has a strong following. So I think it's worth talking about what was in it. So they actually have different Medicare for All plans, But at the end of the day, at the heart, they were the same in terms of these two bullets. They wanted to expand Medicare, which is currently the 65 plus insurance, and make it available to everyone. Non-option, everybody gets it. In addition, there would be no other options. So the positives on this is it's a very strong moral argument that a lot of people in the United States believe, and the majority of Europeans believe, is that it is a moral obligation of a government to provide health care to its citizen, to its population. Very similar to providing clean water and education. It's the obligation of a government to provide access to health care. So the positive, that's the biggest positive of this plan. And it simplifies things. It gets rid of this incredibly complicated system and just moves to one system. The concern is twofold. The first is the financing of it. Now, Elizabeth Warren, more than Bernie Sanders' plan, did outline how she would pay for it, but there is a concern. And just to contextualize, the current Medicare for the 65 plus crowd is good, but there's enough holes where 65% of the population want something in addition to it. But that plan or that coverage cannot continue as is because it's running out of money. In the next 10 years, something has to change for that funding to continue. The current payment structure as is will not last for over a decade from now. So the current system essentially is running out of money. And what we're saying is we're going to cover everyone and we're going to make it better coverage. And so you can think of the financing required for that is pretty astronomical. And then on top of that is the current versions of these plans, as they are written, are the most extreme single-payer system proposals out there. You often hear individuals argue a lot of other countries have made single-payer systems work, and that is absolutely true, and we went over multiple examples earlier in this talk, but every single one of those countries has supplemental insurance allowed. So to say there is no way to fill in the holes, and there will be holes, scarcity exists, you cannot cover everything. To say there's no way for people to buy additional insurance to fill in those holes would be the most extreme version out there. And it's not necessarily a bad thing that generally who fills in the holes are the wealthier people. It's not necessarily a bad thing for society that that happens. If you take Sweden and the UK, that's 10% of the population that gets out of the queues, that gets out of the long wait times, and it makes the wait times for everyone shorter. So it's not necessarily a bad thing that they allow for people to buy supplemental insurance and get out of the basic plan. But that is not in this plan right now, and that is one of the concerns about it. So Biden wants to build on Obamacare. So keep essentially those of us who have employer-sponsored health care, let's keep that. He would reinstate the federal subsidies, so they're not gone yet, but there's been, again, talk that they are going to disappear, and he'd increase them. In addition, he would get rid of the loopholes that are being loosened to allow health insurance that isn't deemed quality health insurance to be offered, so he'd increase that regulation, very similar to all other nations. What he does not publicize and what he will not say in a stump speech is that to keep insurance prices down, he would most likely need to reinstitute the penalty. In addition, he would like to have a national public option. And this is something, just a little historical perspective, was originally in the ACA but got taken out at the very end, is let's not have a single payer system, but let's give people the right to buy some bare bones plan like Medicare. So a federally, and he hasn't fleshed out the details, but this is a baseline insurance program that the government helps standardize. That's very cheap, that's available to everyone. And in his plan, this would be fully subsidized for those in the 14 non-participating Medicaid expansion states to have. So he has a way for those states that refuse to expand Medicaid. He has a way for that higher uninsured population to automatically, without paying, qualify for this public option. And anyone else who wants this cheap baseline plan can buy it. And the details aren't there, but it's assuming it'll be probably income-based sliding scale payment structure of how much you pay for it. So the pluses is this is, you can see it as, in terms of practicality, easier to implement. A lot of the structure is already there. It's just kind of beefing up on it. The con to this is he would have to find a way to reinstitute that highly unpopular penalty, which again is necessary for the private insurance market to work. The alternative that the private insurance market comes up with is the pre-existing conditions exclusion and not letting sick people buy into their plans. That is seen as even more unpopular, but it's tough without taking a health econ course to understand that this penalty is eliminating the pre-existing conditions exclusion. So hopefully I've done a decent job of explaining that it is an unpopular thing to tell individuals in the United States, you have to buy this or you'll be penalized. So that is probably going to be his hardest selling point to succeed in taking, getting rid of our uninsured population. So the Republicans, the one place they agree is they don't like the ACA. And they cite more principal reasons of government overreach and not enough individual autonomy or state level autonomy. So they agree that they don't like the ACA, but they really haven't been able to agree on what should replace the ACA. So a lot of Republicans in the Senate and Trump also ran, and one of their major platforms was to get rid of the ACA. And so right away, right when they got elected, they went to work on what was known as a repeal and replace. And they all agreed they wanted to get rid of the ACA, but when it came down to details on what would replace it, they could not agree. And so the first attempt to repeal and replace the ACA never made it to the Senate floor because they just could not agree what was in the, what would be in the replacement plan. A second attempt was called the skinny repeal. And they said, you know what, we all want to get rid of the ACA, so let's just get rid of it, and then that will force people to come together to come up with a new plan because the ACA would be overturned and all the changes to the insurance market in particular would be overturned, and that would force us to come up with new regulation. And that did make it to the Senate floor, and they thought they had enough votes to basically get rid of the ACA. It was saved by a single thumbs down vote by the late Senator John McCain, who flew back from getting treatment to vote on it. Most thought he was going to vote for the repeal and basically eliminate the ACA, but he voted against the repeal, and so he single-handedly essentially saved the ACA. So there is no single plan that the Republicans have, but from listening to them, there are some common themes. So I'm just going to talk about the themes that the Republicans are pushing for. One is to, instead of pay a percentage of Medicaid payments through the states, give them a fixed amount of money called block grants. And the positive to that is it controls what the federal government spends on healthcare for the Medicaid programs, so it helps with the deficit. But the concern is this would really penalize the states that went forward with the Medicaid expansion, because they would have to, in almost all states, come up with more funding and take money out of other things to continue to cover Medicaid without further help from the federal government. And that's known as a block grant. The Republicans point to the 65% of seniors that buy supplemental insurance on top of Medicare and say those seniors love it. So why don't we just give seniors a fixed amount of money and they buy insurance on the private market. And that way we would eliminate the government's burden of spending on Medicare, and we could control it. Again, we'd know exactly what we're spending. And in addition, the traditional free market mind frame of let's not have as much mandates in terms of what insurance should and should not be. Let's let the insurance markets cover it. So the positives of these plans is it does increase individual autonomy and individual choice. The concerns of these plans, particularly privatizing Medicare and relaxing insurance laws, is tied to the fact that insurance is such a complicated product that it would be very easy for insurance companies to take advantage, especially of vulnerable populations like the elderly. Can you really, by relaxing regulations, be assured that the senior citizens actually are going to buy quality insurance? And so there is a massive concern, which is shared by all other multi-payer systems, that you need a lot of government involvement in these markets to protect consumers because it's so complicated. You need some standardization in terms of what qualifies for insurance that should be offered, especially if you're going to privatize the market and give it to seniors. So yes, these plans generally will increase choice, but it will, the risk of consumers being taken advantage of is pretty high. In addition, the general Republican approach, although they don't say it, most likely supports bringing back the pre-existing conditions exclusions. And why I say that is they're against, government intervention, and the private insurance market's way to incentivize healthy people to buy insurance is to have those pre-existing conditions exclusions. So the general Republican principles and approaches to the health insurance market would most likely significantly increase the uninsured population, which is a concern that we talked about and addressed multiple times. Okay, so there are some states that are making some changes to reduce their uninsured population instead of just waiting for the federal government to do something and make. So leading the way are Washington State and Colorado, and they both are instituting and passed legislation to institute a public option. So this is not a publicly run plan. States don't fund it, but they heavily regulate it. So Cascade Care, for example, in 2021 in Washington State will be a bare bones cheap option that the state has heavily regulated that will be available to anyone buying insurance on the individual marketplace. Colorado 2022, very similar. It's an option, so it's not forced on anyone, but it's a bare bones insurance plan that is privately run, meaning it's going to most likely be offered by a nonprofit insurance company, but the state is heavily involved in controlling what's covered and the prices that are charged. They are leading the way. States have expressed either interest or pass legislation to research public options. So the states that are looking to do something similar and are at various stages of doing something similar to Washington and Colorado are on the left. And then other states are saying, let's figure out a way to just have people buy our baseline plans, the Medicaid plans. So most likely, and there's some states that, again, have passed legislation to research this. None have actually passed legislation to implement it. But our Medicaid is very baseline insurance, and this is something some of the presidential candidates, Klobuchar and Booker, actually supported on a national level, is just let's allow people to buy Medicaid. Probably based on income is how much you're going to spend for it, but let's give them the option to buy just the baseline insurance. And so there are states that are saying, okay, we have an uninsured population. It is a burden on society. It causes inequities, and it just makes the public health sicker when individuals get sick and have nowhere to go. And so you can see that the states several states are not waiting around for legislation to change at the federal level. Our key takeaways. We have an uninsured population, and what we see are there are different ways to increase and eventually achieve universal health coverage as defined by everyone in a population having health insurance. And there is not one ideal approach. You can't point to a single country and say they have it right. There are trade-offs in all of these approaches. And what we see is what is being proposed emulates a lot of what we see in other countries. And depending on the upcoming elections, you hopefully through this talk have gotten a feel of what you're going to see and also the issues that are going to be debated on healthcare as the elections get closer to us. So thank you if you've made it this far. I hope you found value in this talk, and thank you again.